Ingrid, you can
I'm
start.
ready. I'm ready.
Yes. Hello, everybody.
Hello, everybody, and good afternoon. A very warm welcome to our new webinar session. My name is Ingrid, and I'm the Administrative Director at Swiss Medical Gate. If you haven't participated to the previous webinar, let me introduce you shortly Swiss Medical Gate. Swiss Medical Gate is an international medical center, and we are located in Geneva. We're working exclusively with a Swiss leading medical expert, well-known professor and doctors, and Swiss leading medical institutions, such as University Hospital, but also private hospital like HOPITAL Latour in Geneva, who offers you the same services as a teaching hospital. Actually, the two doctors that you will listen to today, Professor Pralong and Dr. Mégevand, are part of this beautiful institution. As you may know, we work mostly with medical travel partners all around the world, and we thank you to be one of them. How do we work? We work as a medical coordination. We coordinate all medical services and, if necessary, the administrative formalities for the patient and for their relatives. We are your contact. We are your partner as a bridge between your client and the medical institution. We are there for you and for your client from the beginning until the end. It means that we are here to help you from your medical demand to the departure of the patient. We do our best to give quality service required. Talking about the webinar, we would like to inform you that it's conducted in English, but also in Russian. For the Russian-speaking participant, we have a Russian room, and if you wish to join this room, our webmaster, Alexander, will explain this to you right now. Alexander?
Всем добрый день, коллеги. Меня зовут Александр, и сегодня я осуществляю техническое сопровождение семинара. Убедительная просьба всех присутствующих выключить свои микрофоны, дабы не создавать помех для спикеров. Если у вас будут возникать какие-то трудности, вопросы по технической части, вы кого-то не видите, не слышите, вы можете смело писать в чат, я постараюсь этот вопрос оперативно решить. Как уже сказал Ингрид, я повторюсь, концепция вебинара подразумевает перевод на русский язык, поэтому всех желающих, кто хочет слушать на русском языке, я прошу вас написать в чате, и вы будете переведены в русскую комнату. На этом все. Приятного просмотра.
Ingrid?
Yes. We would like also to inform you that this webinar is recorded, and within the next following weeks, actually we will have our own channel on YouTube, and everyone will be able to watch it online. And nevertheless, we have two recommendations, please. We'll kindly ask you to turn off your microphone and your camera. If you have any question, you have two choices. Either you can leave them on chat and we will read them for the doctors and he will answer to it at the end of the speech. Either you can send by chat the request to talk directly to the doctor, and you'll have the chance to speak to him in English and ask your question. The medical part will be led by the doctors, and I will leave you now and let Dr. Rabaeus, who's our Chief Medical Advisor at Swiss Medical Gate, to carry on with you, and I wish you a pleasant webinar. Thank you very much.
Thank you, Ingrid. Yes, so I am Michael Rabaeus. I have probably met most of you already now, but I hope there are some news. And I am then, as Ingrid said, the Chief Medical Advisor of Swiss Medical Gate, which has as a purpose here to take care of international patients. And I'd like to underline that our motto is that the patient always comes first in choosing the different type of treatments and investigations. Today we are going to speak about weight problems and how you can solve them with different interventions. among which you also have surgery that can be used. So it's my great pleasure to introduce to you today Professor Pralong, endocrinologist, and Dr. Mégevand, surgeon, who are specialized in this very, very modern problem, I would say, that we are facing the occurrence of lots of different problems according to different weights, etc. Sorry, I lost my mind. So it's my great pleasure then to turn over the chair to Professor Pralong, who will comment on different aspects of obesity. Thank you for being here, Professor.
Thank you very much for the invitation indeed. Please, if there are any technical issues, just say as it occurs so that we don't carry on not realizing that there are technical issues. Well, I will start the presentation and then my Mégevand will continue. And maybe I should put up the slides, which is now here. Do you see that properly?
Yes.
Okay. So the idea was to talk about novelties in the treatment of overweight and obesity. And before we do that, we agreed that I will very briefly, in a couple of minutes, summarize what the medical condition we envision when we talk about overweight and obesity, before sharing with you a couple of things that we believe are pretty novel in the way to offer treatment to these patients. And to echo the comment of Dr. Rabaeus regarding the new disease that obesity is, in fact, Professor Arnaud Badevant, who was the head of endocrinology in Paris at Hôtel Dieu in the early years 2000, he called them, and he was one of the main writers of the first initiative towards treatment of obesity in France. And he called the obesities diseases of the economic transition. And I think this is something to keep in mind, that really our way of life is at least partly responsible for this disease. It is defined by WHO as an abnormal or excessive fat accumulation that presents a risk to the health. So this is really, if you pull it up from the net, this is what you will find. But of course, the definition goes a little bit more precise when we try to figure out the degrees of obesity that the patients are suffering. And the definition relies on a marker that we can discuss later, is, you know, a marker that has its strengths and weaknesses, but it's a very easy one. It's the body mass index. It's calculated as the weight of the patient divided by his or her height at the square. And between 25 and 30 kilos per square meter, we talk about overweight. And from 30 kilos per square meter on, we talk about obesity. And when it reaches 40 or higher, we talk about extreme obesity or morbid obesity. It is clearly a disease, and that's according to WHO again. It has an impact on the health, and this disease is all at once chronic, complex, multifactorial, and we're going to come back to that, and relapsing. So this is a disease that requires the attention of different specialists, and particularly its multifactorial origin. And this is one of the novelties that we will address in a few slides, the fact that to really take into account the complexity of this disease and offer potential solutions to the patients suffering from it, one really needs to have different specialists working as a team. I think that that's very crucial, and that's one of the novelties that we propose here and we offer here at Latour. When we talk about a multifactorial disease, these are a few of the different causes that can lead to the development of obesity. And these causes are very different. I mean, there are clearly genetic predisposition to obesity. And I'm really talking about predisposition because the real genetic causes, when you have one gene, or not real, but the monogenic causes of obesity, when you have one gene causing one obesity, that exists, but that accounts for less than 5% of childhood obesity. So it's a very rare disease as a Mendelian inherited disease, but genetic predisposition clearly exists. Some hormonal disturbances clearly can lead to obesity, rather rare, probably less than 10% of all obesities. Some drugs can lead to very massive obesity development. Sedentarity and nutrition, the lifestyle factors, are predominant causes of obesity. But all these causes, they can coexist in a given patient. And to finish with this introduction, there's another point that I think is really important to remember. And this is something that when I was a student and when I was a young doctor training in the hospitals, we were not taught this, that we are not all equal in face of the caloric load. There are different susceptibilities to caloric load, and that means that eating a very similar diet, some people will be prone to weight gain and others not. And one of the very important determinants of this individual susceptibility is shown here. It's the intestinal microbiota. I don't want to talk about that because this is not an avenue of treatment yet, but this is to be remembered that, you know, not everybody will develop the same weight gain with the same diet. So just to remind everybody that this is a very complex disease. Keeping this in mind, I think the evaluation of a patient suffering from overweight or obesity, who, as was said before, is at the center of our attention, should really be done according to several dimensions. And again, this makes, I believe, a strong point towards a multidisciplinary approach of that disease. Already starting at the evaluation. And the evaluation is summarized in this slide according to the somatic dimension, to the nutritional dimension, to the psychological dimension, which can be very important because feeding disorders can be present at the development of obesity, and with the physical activity dimension. And here at Latour, I cannot stress enough that we have professionals that are able to provide that sort of evaluation to our patients. They know this disease, they know this pathology, they know these patients, and they know how to evaluate them and make the starting evaluation according to the complexity of the disease. I think that is very important. I'm not the only one to think that, nor is my colleague Jean-Marie Mégevand sitting next to me, because this scheme really summarizes that. And I think that's one of the important points that I wanted to make today. This was published a couple of years ago, and this is a graphic that was published by the National Institute of Medicine, that's the English Institute, when they published their recommendations for the multidisciplinary assessment and treatment of adults and children suffering from obesity. And what you can see here, I don't know whether you see my arrow, but there's two circles that are extremely overlapping. The circle on the left is the one that regards the medical part of bariatric surgery multidisciplinary clinic. These are the people who will participate in the evaluation of the patient. And on the right, but with this huge overlap, there is the actual bariatric surgery team, which again encompasses a lot of different specialists, and Jean-Marie Mégevand will tell you more about that. And these two teams really should be working very closely together, and ideally, as indicated on the far right here, it should be a combined weight assessment and management clinic team with a bariatric surgery multidisciplinary team. And this is what we have set up here in Latour. We have a completely integrated team. It is a single team which is able to offer both the conservative options and the surgical options for treatment, with all the different dimensions that I've alluded previously, and these are the evaluations that maybe Jean-Marie Mégevand will talk to you later. But the important thing to remember is that we provide this integration here at Latour. When you talk about tackling obesity as a weight management in a weight management clinic, as do the English guidelines suggest, and I think it's a very good idea to do that, because you put the patient at the center, make him responsible for his objective, and you set goals. And like for every project, you have means that you can activate, and you have goals that you want to achieve. And as a rule of thumb, and rule of thumbs are always there to be proven wrong, but as a rule of thumb, when we talk about lifestyle changes, whatever that is, everything, and we reach a 6 to 10% decrease in the starting weight, or 6 to 10% weight loss, this is a good success. When we shift to drugs, there's not many. Obesity, as prevalent as it is an orphan disease. There's really, in my opinion, one drug on the market that is worth mentioning, and I will mention it in a minute. When we reach between 8 to 15% weight loss, this is really a good achievement. And so surgery remains the only therapy that can really provide a very significant weight loss. But the major difference with surgery, I think, when it stands out compared to other options, is the durability of the weight loss. And I'm sure Jean-Marie will address that later. It's not to say that other approaches are useless at all, and I will finish my presentation by addressing that. I wanted to talk to you about that one drug, which I think is very promising, not because it's not there, it has been there for quite a while, but there are evolutions and there are new GLP-1 for glucagon-like polypeptide-1 analogs that are coming on the market. Liraglutide is widely available throughout the world, and it's the first of a family of drugs. It's not a drug, actually, it's a hormone agonist, which shares effects on both energy metabolism and glucose metabolism. And for the sake of this presentation, I've just summarized here the effect that liraglutide has on energy metabolism. And when you want to induce weight loss, you have to somehow play or modify or work with energy metabolism, of course. So this hormone analog is a very strong stimulant of satiety and of the feeling of fullness. So it will help patients, particularly patients who suffer from what we call prandial hyperphagia, a tendency to overeat at every meal. It will decrease hunger, it will decrease the drive to go looking for food, and it will overall decrease the energy intake, and it's a drug which, combined with physical activity, is extremely efficacious to lose weight. It has a series of side effects. It makes it sometimes difficult to administer. The actual response to the drug is not universal, as is shown on the next one. This is just a schematic of the weight loss achieved over 56 weeks against placebo in a small cohort of patients. And you see that the average weight loss achieved was 8%, which is the lower end of the interval I was showing you. But in fact, there are good responders and bad responders. Most patients, you see here, lose between 5 and 10% of their weight, with a number of patients, probably a third of them, losing more than 10% of their weight. So a decent to good outcome with a drug that is very easily administered and that has side effects that fade away with time. So it's a very good option depending on what your target is. And I will finish with that because I showed you the different targets that one should have in mind according to the means that we want to mobilize. But this last slide, I'm trying to make a very strong and important point here. These are the proven benefits of a 5 to 10% weight loss. And these benefits have been and have been repeatedly proven. So that means that it's not futile. It's not futile to use an approach that will provide 5 to 10% weight loss, because you will improve your cardiovascular risk, your metabolic risk of type 2 diabetes, your lipid, your lipid profile risk, your blood pressure, your obstructive sleep apnea syndrome, and overall your quality of life. So it's true that you don't reach the same objectives with different approaches, but when you induce a 5% weight loss, and it's now even down to 3%, the English recommendations, the National Institute of Medicine recommendations now clearly state that a 3% weight loss is already inducing significant health benefits in the patient. So we're left with an array of options, the most efficacious and probably the most durable being the surgery. And I'm going to give the word to my colleague to continue with the presentation on this other option.
Okay, thank you, François. Hello, everybody. I'm Dr. Jean-Marie Mégevand. I'm a bariatric surgeon here in Hospital de la Tour. As you saw in one of Professor Pralong's slides, probably the surgery is the best way to lose weight, I mean more than 25%, in a matter of long term as well. But of course, you need to get some criteria, because not everybody will go for surgery because they don't have the criteria. And even though some people, they have the criteria, but they are not ready for surgery. So we are not pushing people for surgery. This is important. But some people who are ready, they will benefit widely of this approach. So those criteria are quietly international, and you need to get a BMI over 35 with or without one or several comorbidities. Though the comorbidities are usually hypertension, diabetes, and sleeping apnea syndrome. In some situations, we could consider surgery on patients over 30 as BMI, but for example, with severe diabetes. We call that metabolic surgery. And it's coming over and over, and probably we will get that surgery recognized by all the instances all over the world. You need, first of all, as Professor Pralong said before, you need a very strong preoperative evaluation by the endocrinologist, the dietitian, psychologist. This is very important, and sometimes it can take 6 months, but it's very important. And you have to accept that you will be followed after your surgery, and this is important because we know that the quality of the results after surgery are really dependent of the follow-up and the physical activity that the patient will be able to go back. Okay, so among a lot, of course, I put only the main surgical procedures which are done all over the world. There are a lot, but the most frequent are the gastric band on the left, on the top. Then you have the sleeve gastrectomy, and then below on the left you have gastric bypass, and on the right below you have the switch, duodenal switch. So in Latour, I've done a lot of gastric band, but the results are quite poor, and in the long term there is a lot of complications which push the patient, which leads the patient to come back to surgery to change the surgical technique, because they gain again weight and they have pain or problems. So in Latour, we kept only 2 procedures which are widely the most done procedure all over the world. This is the gastric bypass and the sleeve gastrectomy. The duodenal switch is a good surgery, but it leads to very high complication rate and a lot of lack of carences of vitamins and everything. So this is the 2 main surgeries we do in Latour. So of course, a long time ago, we used to do this surgery by open surgery on the left. And now, of course, all those procedures are made by laparoscopy, the keyhole surgery, so minimally invasive. So the choice between the 2 techniques, very quickly, normally we propose gastric bypass to people who are really strong smokers, sweaters, or who have quite strong comorbidity such as diabetes. Because the long-term results with this technique is better on the comorbidity. We propose sleeve gastrectomy for the people who are really overeaters. They don't snack. The young patient is important because everybody has a tendency to gain again some weight. And if you have a sleeve, you can maybe propose to the patient to convert maybe 10, 15 years after to a gastric bypass. And of course, there is a condition you have to get to prove that there is an absence of reflux, gastroesophageal reflux, because the sleeve increase the pressure in the stomach, and it can really aggravate the reflux. So why do we propose surgery? It's not cosmetic. It's as Professor Pralong said, it's a real disease, and we propose it because if you leave patients being over 35 or over 40 as a BMI, they will have a risk of dying much superior to the comparative people without obesity. So you can see that with surgery, you can decrease almost 89% of risk of death. Of course, it means that you have to get a follow-up and you have to help people to continue with this weight loss, which is quite difficult, but important. Of course, we do surgery, and it's related to the previous slide, but because with this surgery, you can really have an improvement or disappearance of a resolution of the comorbidities. As you can see on this slide, 70% for diabetes, 62% for hypertension, 86% for sleep apnea, and hypercholesterolemia, 71%. So this is the end of this presentation, and thank you again, Swiss Medical Gate, for this kind invitation. As Professor Pralong said it before, it's very important that we propose to the people a multidisciplinary approach, and that's what we do here. And of course, before going to surgery, you have to get a gastroscopy. This is mandatory. You have a cardiologic evaluation, and this is really what we can offer here. We have really all the how do you say plateau, the field for platform to take care of on those patients. So thank you very much.
So thank you very much, Dr. Pralong, Dr. Mégevand and Professor Pralong, for a very interesting presentation. I think it really puts all the most important parts on how to try to treat this very, quote, modern disease of overweight and obese people. And I think I would like to underline the very important part of having, as Latour has now, a team. I think it's really a teamwork very much, because it's not only a question of intervening on one or two things, it's a question of also making things work on the long term. So I see that Julia has a question. If you would like to speak, yes, you can do that.
Yes, hello. I would like to ask the respected professors about the question, is it possible to apply this medicine to patients with the history of psoriasis or any kind of allergies or thyroid problems?
You're talking about the GLP-1 analog treatment. Yes, this is a hormone analog which is compatible with pretty much every drug. It's not going to interfere with any drug. It's not going to interfere with any other hormonal problem. The difficulties are more in the side effects at the beginning of treatment. Digestive side effects, headaches, which almost invariably fade away after a few weeks, but sometimes can be really difficult to bear. But there's really not many contraindications or restrictions to use, actually.
Thank you.
Thank you. That was an important part, yes. How, if I may ask you, Dr. Mégevand, how do you look at the side effects of the interventions? What are the problems that one should be preparing the patient to maybe have to face?
Yeah, this is a very good question. I mean, okay, the gastric bypass evidently has more, not side effects, but I mean, you need really a strong follow-up because there is carences of vitamins and calcium that you don't have. You have less with sleeve gastrectomy. So this is a quite big difference between the two techniques. And plus with the gastric bypass, it's very rare, but you can have a strong dumping syndrome. And sometimes it can be difficult to control, but normally we can control it with just dietitian measures. But some of the patients, they need medicine. So this is mainly the long-term complication you can have.
Okay, and then there are some other...
I always like to jump in at this point because I'm not the surgeon. So I have the vision of the internist and the surgery. And I think it's pretty safe and really very appreciated surgery by the patients. And when you put all the side effects or undesirable effects which go with the type of surgery, it's between 15% of the patients at most that will experience it over the course of their lifetime. So it's not very prevalent.
Okay. Sorry,
just one point. I never had one patient who told me, if I had to redo that, I won't do it again.
No, exactly.
Okay, that's a good, thank you for that. That's a good remark. There is a question from the Russian-speaking room. What are, well, the side effects of liraglutide you talked about already, and what is the cost, and what is the course of treatment? How long does it have to go on?
Okay, the cost in Switzerland is about 220 francs per month.
Mm-hmm.
Weight loss is reaching its maximum at around a year of treatment. You've seen that graph showing the decrease in weight. It's about a year, and then you have the maximum benefit. There is a well-known demonstrated risk of weight regain at the stop of treatment. So that is something, stopping the treatment is something that must be done with careful counseling for diet and physical activity, as always. And this is a drug that could be pursued long term. I mean, some patients decide that they are feeling so well on it that they decide to keep on it for it could potentially be 4 years. And we have 10 years of experience with that class of drugs, and that's fine.
And in the same line, if patients only have to lose 5 or 10 kilos, do you recommend to take also these type of hormonal drugs?
Oh, definitely. It can be very useful to break a wall. You know, sometimes you are against a wall, and whatever you do, it's not working. And this is that disease. And it can be very useful to help trigger the weight loss.
There is also another question is your stand on metformin for non-obese patients, as in some doctors recommend metformin for everybody above 40?
That recommendation, in my opinion, stems from data on longevity more than data on weight. The universal recommendation to take metformin is more because it induces changes at the cellular level that are the changes that you see with caloric restriction, which is the only means of significantly increasing lifespan in basically all life, all biological life. But it's a very minute effect. Regarding weight loss, it is also a relatively minute effect. Metformin is a great drug. It's a very old drug, very safe, but I don't think that the weight loss that you can achieve with metformin outside treating hyperglycemia or diabetes or pre-diabetes warrants taking it personally.
And we, as you said, insulin sensitivity is also very much influenced by just doing physical activity. So
absolutely. Oh yeah, they're equivalent actually. Yeah. The sad realization is that it's easier to keep on a drug than to keep training. That's what every study shows, study after study.
I know. The question, alpha lipoic acid. I don't know what it is.
Oh, you get me there.
Okay, so then I'll go on. Vitamin D for treatment and prevention of obesity, question mark.
You don't want to start me on vitamin D.
Okay.
We could talk, no, we could talk about all the alleged good effects, positive effects of vitamin D for 2 hours.
Yeah.
And I'm a great fan of vitamin D supplementation, by the way. I'm not a great fan, it's not the proper term. I really promote and apply, you know, vitamin D deficiency screening is part of my screening in most of my patients. I don't see a demonstrated place for vitamin D in weight management.
Okay. Question also, if patients come to the clinic, how long do they have to spend, I suppose, if they are having a surgical intervention, the global checkup and then the operation?
You mean the time?
Yeah, how long time? How long do they have to be in the clinic or around the clinic?
It's a tricky question because it depends on the evaluation. Some patients they need one shot with the psychologist, one shot with the endocrinologist, and they are quite ready because they've been working a lot on this problem before coming. if the patient is not ready. I think it is the worst thing to do the surgery to a patient who is not well prepared. This is really important, that when you go to the surgery, you know that you have prepared your patient the best as you can, and that the patient is ready. And it is shown in a lot of different studies that the final result depends on this a lot, and of course on the follow-up, but really to prepare the patient. So it's a tricky question. If the patient is ready, it can take 10, 15 days. If not, maybe he has to go back.
Yeah, 2 visits. Then
yes,
if not, then that would be 2 visits.
So I think that answers the question that was made, and then we have answered all questions on the converser. Does anybody else have any question? Apparently not. So gentlemen, it was a very great pleasure meeting with you over the webinar. I hope we meet again soon. And I will then thank everybody and turn back the chair to Ingrid, if you also want to say the closing words.
Yes,
It was a
sure.
pleasure as usual.
Sure, it was a great pleasure. Well, thank you, doctors. Thank you to all of you for your participation. I would just want to make sure that there is no more question in the Russian room or beside that. I think we are all clear. Dr. Rabaeus went through, and just no, looks like not. Okay. Well, next webinar will be held on Thursday, the 18th of June. Just to let you know that there will be so far no webinar for next week. The next webinar will be ENT. It will be discussed by Professor Dulgerov, also from HOPITAL Lato in Geneva. You will once again receive the registration form as usual. And please feel free to spread the word around you. If you know anyone who's interested, it can come with great pleasure. I will leave now the final words to Marina, our managing director. And I would like to thank you once again for your very kind participation. Thank you.
Thank you.
Thank you, Professor. Thank you, doctors. Thank you, everyone, to being with us. I will now say a few words in Russian for our Russian participants. Дорогие коллеги, друзья, большое спасибо за участие в этом семинаре. Я думаю, что эта тема была очень интересная. Пожалуйста, пишите нам, обращайтесь, пишите нам ваше мнение, пишите нам ваши вопросы или ваши пожелания. Надеюсь увидеть вас в следующий раз. Thank you everybody, and see you next week, next time. Bye.
Bye-bye.
Thank you, bye.
Bye, thank you.
Thank you.